Hello again, Stephen. As you know, I work in the medical field, so it was kind of an inevitability that my videos on this channel would eventually take a turn to being more medically centric. And so today we're going to be talking about D-dimers. For those watching this video in isolation from our other videos and don't know, I am an emergency department nurse, so my perspective is limited to that. I cannot speak as a physician or somebody who's worked in a long-term care setting. We're going to start out with a quick lesson for the non-medical people watching. A D-dimer is a blood test we use in a clinical setting to test for the likelihood of a clot in patients. I'll keep this very short and simple. When coagulation occurs in the body, which can be activated for a number of different reasons, a clot or thrombus forms, and then when that clot is subsequently broken up by enzymes in the body, you get a bunch of different byproducts and fragments floating throughout the bloodstream, and one of those fragments contains the D-dimer. Okay, so why order a D-dimer test? Well, that's kind of the point of why I'm making this video today. At the risk of overgeneralizing, the D-dimer in an emergency setting is largely pointless, because the obvious explanation for ordering a D-dimer, you might be thinking, is that we're testing to see if a patient has a clot, but there's two problems with that. Problem number one is that the test is not diagnostic, which means even if you have an elevated D-dimer test, that does not diagnose you with a clot. And then problem number two is the test is non-specific, meaning that even if you have an elevated D-dimer test, that still doesn't tell us where you have a clot in the body. You could have a clot in the brain, which could be causing stroke symptoms, which if that's the case, you're not going to be ordering a D-dimer test, you're going to be ordering head CT to rule out hemorrhage, and then you're going to be moving forward with stroke protocol treatments. You could have a clot in the leg, also called a DVT or deep vein thrombosis, or you could have a clot in your lungs, also called a PE or pulmonary embolus, which, from what I've seen in my experience, is the number one reason that physicians would order a D-dimer test in the emergency room. A patient will present to the department with classic symptoms of a PE, such as sudden onset shortness of breath, dull or sharp chest pain, low oxygen saturations, even despite giving them supplemental oxygen without a concurrent diagnosis of COPD or asthma. What should happen, if there's a reasonable concern for PE, is we should order a CT scan, specifically a CT-PE study with IV contrast. Alternatively, for those allergic to IV contrast, you could also do a VQ scan or ventilation perfusion scan, but that might not be available depending on the size of the facility that you work at. But the point is either of those tests have the ability to diagnose a patient with a PE. So why do providers not just go straight to ordering the scan? Why do they order a D-dimer in the first place? Well, there's a couple of reasons for that. First, some providers take issue with the scan itself. They don't like exposing all of their patients to unnecessary radiation. Also, kidney function plays a big role. It's ill-advised to order a CT scan with IV contrast in renal failure patients because since their kidneys are not functioning optimally, they're not going to be able to excrete the IV contrast. And last but not least, the patient could be pregnant, which in that case, obviously, you're not going to want to expose a pregnant patient to high amounts of radiation. There are other reasons they don't order the scan, but that's just to name a few of the popular ones that we see. So what do they do if they're hesitant to order a CT scan? They waste time and order a D-dimer test, and when that comes back, do we have a differential? Do we have a diagnosis? No, of course we don't, because like I said before, the test itself is not diagnostic. If the D-dimer comes back positive or elevated, of course we're going to move forward with the CT scan from there, but even if it comes back negative, if they still have a reasonable suspicion for a PE, they still are going to move forward with the scan. They will do this, and I know this because I've seen this happen multiple times, where they will see a negative D-dimer test and they will move forward with ordering a CT scan anyway. Even pregnant patients I've seen scanned before with a negative D-dimer test. And so then when you compare the D-dimer test and the imaging, how do those tests come back? Well, any way you can imagine. I've seen negative D-dimers come back with positive PE scans, I've seen negatives come back with negatives, positive D-dimers come back with positives, and I've seen positive D-dimers come back with a negative CT or VQ scan for a PE. Which is why I hate the test. It doesn't tell us anything and it wastes time. If they're worried about a PE, they just need to order the imaging. That way we're not waiting around for hours for the D-dimer to come back. Meanwhile, the patient could decompensate, they could be more unstable, which if that's the case, getting an imaging at that point is going to become that much more difficult, and then you've deprived that patient of hours of treatment that they could have been receiving for a PE. Now, even though I know I'm making this video about how much I hate the D-dimer, I do realize that it is not an entirely pointless test. It can be useful in diagnosing certain blood disorders. It can be useful in the inpatient setting. Some admitting physicians or hospitalists like to order a D-dimer test as a part of a battery of tests for patients that are admitted to the hospital when time's not so much a factor, and they just want to throw everything at the wall and see what sticks. I just think in the emergency setting, the test has no place. It is not going to diagnose, and it's not going to essentially discourage us from ordering subsequent tests. All it's going to do is delay care and slow things down, and one of the worst things that you can do in the emergency department is slow things down. And that is the end of the rant, Stephen. I will talk to you later. Bye.